My name is Stephen Foster, for those that don't know me. I'm meeting some of you for the first time. I'm the president of NALHE Texas Gulf Coast in Houston, Texas. Our chapter has been up for about a year. We'll actually turn a year in July, so we've been busy, obviously, since then. I'll be your host tonight, and that means you need to go easy on me. Con tranquilidad, por favor. It's my job to keep us on time and keep that conversation moving. We have a lot of ground to cover, a lot of juicy topics, so that's why I'm going to be a kind of a time Nazi. But obviously we have a very special national meeting tonight, which in my opinion speaks to the mission of NALHE, which is to support policy, legislation, and regulation, and to seek to improve health and healthcare for diverse communities. And on February 10th, the White House press briefing released the following statement, and I quote, "As the COVID-19 pandemic continues to plague the country, it has had a disproportionate impact on some of our most vulnerable communities. Shortly after COVID-19 was first identified in the United States, disparities in testing, cases, hospitalizations, and mortality began to emerge. These inequalities were quickly evident by race, ethnicity, geography, disability, sexual orientation, gender identity, and other factors. President Biden and Vice President Harris have released a national strategy to combat the pandemic that has equity at its core. To help ensure an equitable response to the pandemic, the President signed on executive order on January 21st, creating a task force to address COVID-19 related health and social inequities," end quote. So we are honored tonight to have Dr. Octavio Martinez, one of the 12 Health Equity Task Force members here to listen and learn from our national chapter subject matter experts. You guys are the top, and I wanted to make sure you knew that. But first, I wanted to welcome Rolando Gomez, Executive Director and past President Chair of NALHE, who introduced Dr. Martinez. Ro, take it away.
Thank you, Stephen. And I echo Stephen's sentiments around having each and every one of you be with us tonight. And in this forum, I wish we were live and getting to hug each other and shake each other's hands, but that's not the case, at least not yet. Maybe in September, right, Diana, around our leadership summit. But I'm just really happy to be here, and thank you, Stephen, for organizing this, and to Dr. Martinez. What can I say? We're just so humble that you're willing to hear us. So my job today is to introduce you. I'm going to read your bio. I'm sure some of you may have read it before, but why not? Let's do it again. Dr. Octavio Martinez is Executive Director of the Hogg Foundation for Mental Health at the University of Texas at Austin. The foundation's grants and programs support mental health services, research, policy analysis, and public education projects throughout Texas. Dr. Martinez also holds an appointment of Senior Associate Vice President within the Division of Diversity and Community Engagement, where he heads up the Community Integrated Health Initiatives program for the division. He currently serves on the Centers for Disease Control and Prevention's Center for Preparedness and Response Board of Scientific Counselors, and on the National Academies of Sciences, Engineering, and Medicine's Health and Medicine Division's Roundtable on the promotion of health equity. Additionally, Dr. Martinez is a commissioner on the Texas Judicial Commission on Mental Health, an executive committee member of the Texas Child Mental Health Care Consortium, and a member of the Austin State Hospital Redesign Steering Committee. Dr. Martinez, I hope you learn a lot from our amazing leaders today. They have worked hard to provide answers to each of your requests. So if there's anything you would like to say before we get started, I will allow that to you. Give you some moments to introduce yourself. Anything you'd like to say to us before we begin our conversation.
Well, thank you, Ro, for that kind introduction. And I don't want to spend a whole lot of time because I really want to hear from you. I'm very honored that Stephen Foster reached out to me shortly after my appointment by the president, because this is an important group, one that's very close to my heart, being a Hispanic Latino myself in our communities, but recognizing how it's impacted us so harshly, of course, other communities as well. So let me stop there because I just want to say thank you so much. I know this is after hours. This is above and beyond the call of duty and I understand and respect that. But what you tell me today, I'm going to take notes. I greatly appreciate everything that's already being sent, and I will definitely send this on to the task force for that all of us at the task force can learn from what you're about to share with us today. So thank you, Ro.
Bueno, como se dice, vámonos. Tonight you will hear from Eddie Cruz on access and quality of care, Marcos Pesquera, and we'll then discuss structural drivers of healthcare. Laura Castellanos will share work on data and analytics, and Diana Caudillo will close us out with communication and community engagement. I will also mention that we have audience on that consists of chapter presidents from around the nation who also represent different subject matter expertise. So panelists, as a reminder, each of you will have roughly 10 minutes to present your topic, background, data, go over examples. After those 10 minutes, I'm going to try to turn it over to Dr. Martinez, ask any specific questions that you want to hear more about Dr. Martinez. We'll give that hopefully about 4 minutes or so, and then I'll open it up to our panelists, to the rest of the audience to see if they have anything else to contribute to that. I want this to be an organic discussion, so feel free to interrupt and just ask questions if you want to hear anything specifically, but I will keep us kind of strict to that 15-minute block so we can get everyone to present on time. So any questions before we get started? If not, first up is Eddie Cruz. And Eddie, do you want me to run your PowerPoint?
I can share my screen too, if that is helpful.
Perfect. Go ahead if you feel comfortable doing that.
Good evening, everybody. And Dr. Martinez, thank you for your service, your leadership, and ensuring our voices are heard. And a big shout out to NALHE for this opportunity. I'll put my timer on because those of you that may know me, I'm a talker, so I can talk away. Let me tell you a little bit about who Access is. So we're a community health center here in Chicago. We have 35 health centers across 2 counties, Cook and DuPage. We cover quite a large footprint. We service more than 175,000 patients a year, unique patients. 6 out of 10 of our patients are Medicaid. 89% live at or below the 200% poverty level. We serve 16 out of the 20 underserved communities here in Chicago. Our patient population is primarily Hispanic, Latino, and 28% African American. We're guided by a 3-year strategic plan. I won't spend time on this. I just wanted to share. We have 5 pillars, and at the top of our pillar is patient engagement, as that's one of the focus areas that we really use to transform our care delivery model. We have an integrated approach to care. We have both integrated primary care and behavioral health. And, patient is at the core of everything we do, along with the provider, the care coordinator, specialist. And then we have 5 focus key areas around, as I mentioned earlier, patient engagement. Behavioral health is really big for us and our patients. Population health management. So as we talk about quality and risk stratification, how important that is. Social determinants of health. Many of our patients are making decisions whether they come to the doctor or put food on the table. And ancillary services, because we feel that, the total health is also dental, pharmacy, you name it. We really work to include all the different components in the integrated approach. So access and quality care, all things COVID-19, as all of you, it's been a tough 13 months for sure. So really at the onset, we really worked on protecting our patients and staff. We delayed non-essential care. We reduced on-site staffing in many places, 50% or more, to ensure social distancing, and rotated staff throughout the health centers. We quickly pivoted and launched telehealth. We had struggled with activating telehealth, but nothing like a pandemic to really get all hands on deck and making sure that we could reach our patients. And we launched in under 2 weeks our telehealth program across 35 health centers. It allowed us to keep patients engaged and connected. And we did a lot of outreach and patient education. That was critical for patients to understand when they could come in, the screening questions that we all did prior to them coming into the health centers. And then we did a lot of education for our staff and providers as well. One thing that has really helped us is the reimbursement for telehealth. This would be a different conversation if telehealth wasn't reimbursed at the level that it has been. And just, again, quickly pivoting to a remote workforce that could help support the patients where they want it to be met. Around testing, then quickly from that, I moved some of the services from existing health centers to larger health centers and really created 6 testing locations in some of our hardest hit communities, underserved communities. Then we added testing inside our primary care locations for asymptomatic patients. That was really of huge value to us because we wanted to test as many patients. At the same time, we want to protect staff, we want to protect other patients, but we really saw that the model of testing asymptomatic patients in our health centers really was crucial. Did a lot of outreach, created an 800 number, we extended hours, Saturday availability. Transportation, we wanted to make sure transportation was not a barrier, and oftentimes that is. And especially for the population we were talking about, even as we think of the managed cares have a transportation strategy, but it's not effective for our patients. It's like a field trip. If they're picking you up, they may be picking up 5 or 6 other patients, and it becomes a full day event. So we quickly, had a contract, and we did rideshare. Lyft and Uber were picking up our patients and bringing them to the health center and back, no cost to the patient. We took on that responsibility to ensure patients had access. I talked about education. At the testing sites, we had under a 3-minute cycle time at the testing sites. We really, our whole focus was we wanted people in and out. And that was important for us. It was by appointment, so people had to call 800 number and make an appointment, but the time that they spent inside the testing facility was very short. Internal communication, to keep everyone abreast, we were having sometimes daily communication with leadership, and our providers and staff. And then even we did a lot of town hall meetings with community members, getting out to the community, what this all meant, what they could do, what we were doing, what support people needed. It was really a all hands on deck approach to support the patients. In reference to primary care, patients still needed to be cared for through this pandemic. And they still have many care gaps, diabetes, hypertension, you name it. And what we also saw is a big increase in behavioral health needs, right? People lost their jobs, those that were working at restaurants, and how they're going to make ends meet. And so we saw a lot of anxiety, depression through this. So how are we going to, support the patients and meet them where they want to be met? Care coordination has been a godsend. Having nurses, care coordinators follow up with patients, and really making sure that how are you doing was important. And also just again, if care gaps needed to still be addressed, those that we could do remotely, or those that were essential, we'd bring them in, and it was all planned and spaced out so that again, at all times our patients felt protected. Community health specialists, having people out in the community talking to our patients was huge. Again, just to give the word out. PPE, oh boy, when all this, like many, I'm sure PPE was of high concern. Having 35 health centers across a large geographic area, I lost a lot of sleep at night, making sure that there was enough gloves and masks and sandy wipes, and that people had the proper PPE to ensure their safety and the patient's safety. We ended up quickly developing our own kind of stockpile distribution center because with our purchaser, we were distributed only limited stock. So we would order so many, but they didn't have the capacity to deliver what the amount that we needed. And then quickly after that, as soon as the vaccine became available, opened large vaccine centers. Our challenge was that because we are so we cover a large geographic area. We ended up working with 3 public health departments, depending on where our clinics are located, which was a huge challenge. With inventory management, and then there was one incident where we ended up having to cancel patient visits because we didn't have the supplies from the public health department, which was very sad for us. And then soon after, as soon as we could, we started getting supply from the federal inventory, and then worked through that to make sure that, again, that didn't happen again. We've embedded vaccines in the health.
Eddie, let me ask a quick question.
Oh, please, sure.
Very unique that you work with 3 public health departments. What was your experience of the 3 public health departments? Was there a unified message? Was there continuity, or did you find that there was a disparity in what each of them knew and had?
Huge disparities. They had different, in some instances, you couldn't transfer from one we have 35 health centers. We didn't want to waste any vaccines, but there were certain public health departments that wouldn't allow you to take that vaccine or vaccinate anyone for outside of their community. So they forced us into kind of this hole, if you will, where, it was only for Cook County residents. You could not move it to any of our suburban sites. And which presented a huge challenge for us. And then depending on delivery times, one could deliver on certain days, another one could deliver on other days. So orchestrating that, the poor staff that had to do that, we did it and did it well, but there was a lot of inventory tracking. There was daily communication to ensure that at the end of the day, we had the stock when we needed it.
We are at 10 minutes, just saying we can start asking questions just as a time check.
Thanks, guys. I'm very passionate about this, as I'm sure you can tell.
Yes.
So,
Eddie, could you also, what was the experience, and you haven't mentioned it, was it an issue? And if it was, how did you address it? Or how do you think we should address it? As you're thinking a recommendation when it comes to language, or those with limited language, ability in English, in reference to what you just laid out in the model that you guys are working under?
We're very fortunate to, again, many of our providers and staff are bilingual, and our patients limited language and barriers that they have. So getting out front and centered around this in all different types of languages to make sure that people understood the message, and that we were there, and that they can count on us for whatever they needed. They trust our providers and staff. And so that's who they have the relationship with. So one of the things we quickly did also was, especially around the vaccines, getting out there pictures of our providers and staff getting the vaccine so that they could see, oh, if you got it, then I can get it. And then we hit social media with those type of campaigns because that was important. They needed to see that we were okay with that. And we got a lot of patients calling to say, hey, is this really okay? What are the side effects? So we've done at each of our vaccine sites, I have advanced practice clinicians that are there that are able to answer questions as we screen the patient before we give them the vaccine, answering questions. And that has been of huge value. Especially as the time that the patient is waiting for 15 minutes is a great opportunity to engage them in their care. And so having a provider on site has proven to be a huge value for us.
So Eddie, just so I'm clear, language or English proficiency was not a barrier to access with the clinics that you oversaw. But then you're very unique in the fact that you have all these resources. Thinking about that though, and thinking about the bigger picture for the rest of the US, were there any resources that would have enhanced your ability to access and ensure the quality of care that was being delivered during the initial parts of COVID-19?
I think, as I mentioned, the transportation piece has been huge for us, and I'm glad our board and the senior leadership have all continued to stay in that, to say, you know what, we're going to continue to do transportation, and it's not cheap. But the fact that I spoke to a mother. I was at the vaccine site, and I spoke to a grandmother that was there, and as her timer went off, and helping her off her chair, and thanked her for coming, and she's like, no, thank you. She's like, I wasn't coming, my ride wasn't able to come today, so your staff called to confirm the appointment, and I was about to cancel when the young lady offered a Lyft ride to come pick me up. So I'm here because of you guys sending for transportation for me. So people will undergo services if it's too hard for them, or they just don't have the funds to do that. So top of mind, it has been transportation. I'll say also our telemedicine platform has been key to make sure that we continue to provide care to our patients, that we're available. When we were social distancing and remote, our social workers, our psychiatrists were still able to render care. We're still challenged in video. Our patients still struggle around video utilization. And so we have a huge focus on activating and making it easier for video. But we are seeing that patients are not adapting as quickly to that. But for telephone and telehealth, was really great to stay connected.
Eddie, to that point, sorry, Steve, could I ask this one more question? Eddie, to that point, is it broadband, or is it at the end user needing to have either a good smartphone or an iPad or just the computer access, or is it all of those things together?
It's really, everyone's unique. What we're trying to do is really educate the patients, but it starts at the speed that they have at home. And enough bandwidth at home, and then it's teaching to utilize the smartphone, if you will, or the computer. And many parents come in and they come with younger kids, and we do as much as we can to educate. But we there's a huge need around that. Like I said, patients were easy to adapt around the phone, and we would call them and they could easily. But now it's really, what do we do to help the providers and the staff educate the patients more on that utilization? Gotcha.
And Stephen, everyone will be able to share their slides with me?
Absolutely. Yes, that'll be part of this. I do want to open it up very quickly to the rest of the audience. Is there anyone who has a quick comment or underline something that Eddie brought up or add to this conversation? Okay, not hearing anything. So with that, we're going to go ahead and move over, and I'm sorry to have to keep moving, guys. Marcos, are you ready?
I'm ready. So thank you for the opportunity to share some of the recommendations. This is how I looked at it. Things that throughout the years, it has been things that I said, if we really have this going, I think it'll have a big impact on our ability to make a dent on the issue of health disparities and achieve equity. I work for Christus Health, and you're probably familiar with Christus. We're health system headquartered here in Dallas, Texas. We have 60 hospitals and a whole bunch of facilities in Louisiana, all over Texas, New Mexico, as well as Mexico, Chile, and Colombia also. So I lead their diversity, inclusion, health, equity, and community benefit wing for the system. And some of the things that I thought that would be really good to have that could be helpful in the work that we do, requiring health plans and hospital systems and all medical practice and data collection, the race, ethnicity, the age, language, gender, but also social determinants of health and having those assessments. That's one of the projects that we're currently working on. Is implementing the social determinants of health assessments into the clinical process. We're working with, we have a Physicians for Health Equity Taskforce that is advising us on this process. And of course, the fear of follow-up is the biggest thing, because the doctor said, okay, I'm going to collect this data, but connecting patients to transportation, to prescription affordability, to housing resources and other things is something that we as providers don't have time to do. So what do we do once we collect this? And we can talk about that because that's where the community health workers programs come in, and ensuring that we can recommend some reimbursements of some sort for the work that these individuals do, because it's so critical to address social determinants. The other piece also, even credentialing bodies like Joint Commission or NCQA, asking and requirements for all of us to demonstrate quality metric performance stratified by those things that I was saying: race, ethnicity, age, language, even payer mix will be great. So that's around the collection of data. Obviously, interoperability will be fabulous. Every time we refer people from our emergency room to an SQAC or other facilities, we really would like to know what happens to these patients. And we don't, unless we call them over the phone, and that's just time-wise, it's not feasible. So the interoperability of electronic medical records all being together in one platform, boy, what an amazing day that would be. So for ask all electronic medical record software companies to include as part of their basic package a social determinants of health assessments for all patients to complete, so we can better track those things and address the issues that are barriers to these patients. Also talking to health plans and health systems to employ community health workers that can take the social determinants information, facilitate this access to community nonprofits, safety net providers, and alleviate other challenges that marginalized communities are experiencing. I think that's critical. Medicare, Medicaid, and health plans to include in their contracts with healthcare providers reasonable reimbursements for this community health worker interventions, whoever does it, whether it's a health plan or whether it's a hospital, whoever does it, those are movements that need to be recognized as such. All EMRs to have access to a repository of local resources within local communities that serve as a safety net provider and social human services. And that's kind of an interesting thing. And I think different hospitals do different things, whether you get the Anberthas of this world or you get other softwares like that work. But I also see a lot of smaller folks that are scrambling and having little, yellow stickies, all these kinds of things. What a great day will be as well to have all this community resources that have to probably sign up to a portal of some sort, so that way folks can have access and do their referrals a lot simpler. I was thinking about mental health as well, and I think the utilization of licensed social workers and other providers to serve as first responders and counselors for individuals suffering from mental health crisis would be very helpful. Also, one day I did an 8-hour day with a policeman, and just going around town with them. And frankly, half the calls were people in mental health crisis. They were not really crimes. So I think these folks could have a big impact. Also use this social workers or psychologists with police departments or hospital emergency rooms that can access and triage and send to appropriate behavioral health resources. And then incentivize bilingual and minority individuals to go into behavioral health careers. Boy, that is very, very much so needed. There are very few bilingual providers in that area. Around cultural competency, incentivize bilingual and minority high school seniors to enroll in healthcare and behavioral health programs and degrees will be great. As a diversity and inclusion part of my job, that is a big challenge, because I definitely want to represent the communities we serve, not just in race and ethnicity, but languages that we speak. And you're near San Antonio, and you're near, we have 5 hospitals in Corpus and south of Corpus, and the number of Spanish-speaking patients there is overwhelming for the number of bilingual staff that we have. Require nonprofit hospitals to utilize evidence-based, culturally competent approaches to address community needs, such as barbershops, beauty salons, have a closer relationship with faith congregations, even utilization of community centers for outreach and education. Instead of having patients come to us, let's just go out there and enroll in these areas. And then right before last year, require medical and nursing schools to have a robust curriculum around unconscious bias in the medical setting and its impact on health disparities. That is critical. We're doing that right now with our graduate medical education. We have about 150 medical residents, and we started this year. Shameful to say, after George Floyd's death, that's when we started having at least 4 interventions a year, a couple hours each, with this 150 medical residents on unconscious bias in the medical setting. And we're done 3 already, and it has been great and a great learning for them. So that as well. And then also the affordability of the health exchanges. I don't know if you guys hear this, but I do hear it. There's people that are not poor enough to qualify for subsidies, but don't have enough money to they have to decide what to do. So they go without health insurance, particularly in the state of Texas, as you know. So something with the subsidies is not jiving, because there's people that really should be able to get some subsidies and they're not, or maybe the health plans are just charging way too much, and double checking what's going on in there. So I think reimbursement for language services would be awesome too, which I don't think we have that now. I've been told when I push the issue, no, it's part of the package. And I said, yeah, right, but try to explain that to folks. It's not really part of the package. It's an extra thing. I think the deaf and hard of hearing, every time you have to care for a deaf and hard of hearing is $120 an hour, minimum 2 hours. That's $240. And the hospital, the doctor gets paid what, $100 back? And you're paying $240 on deaf and hard of hearing. That there's something that it's not jiving. So, okay, sorry. I think that's kind of in a nutshell what I had prepared, and you do have the note, Dr. Martinez, that Stephen will send to you.
Yeah.
Absolutely, Marcos. Really, really important. Now, you brought up several times, and I really appreciate the financial shortcomings that we have in our current healthcare system. In reference to the reimbursements for the social determinants of health, and really that includes language, as you're pointing out, disability services that are needed to engage with our consumers and our patients. One of the ones that comes to mind for me is a global payment model, as an example, where why don't we give, and we can really adjusted for risk and all kinds of other variables, where it's either the hospital or in the ambulatory setting to a physician or other providers, here's an amount that will cover, say major depressive disorder, with anxiety, as an example, knowing that there are also, physical attributes that come with it, these kind of ailments, because very few things now just sit alone, unfortunately. They come in complex syndromes for us physicians. But have you given any thought to what kind of reimbursement, knowing that fee-for-service, and there's some great research that has recently come out, has failed us tremendously in COVID-19. Many hospitals, but also actually out in the ambulatory setting, our doctors, they lost revenue big time. It just took a huge dip. It has come back, I understand, but it does show how fee-for-service really is failing us, and especially with the issues that you just brought up. So let me stop there to see if you have any thoughts on what kind of a reimbursement model, if you could create it, if we started from scratch, what would it look like?
Oh boy, that's a huge question. You know what? I think going back to the Physicians Taskforce for Health Equity and some of they're so, I mean, the things that they see on a regular basis is pretty sad, and they're so supportive. This is what I feel like. The physicians are they really want to do what is right and the right thing by their patients, but they also know that time is not allowed in their practice. So to me, what I would like to see, even if we have value-based models, that is actually spelled out, that this issue of having community health workers as part of it, if we're not going to, the fee-for-service, I don't like either. I don't want to go there. I'd rather have the value-based, but that it is spelled out that this issue is you pick the provider you want. If you want an LPN, that's fine. If you want an RN, that's more expensive, that's fine. but a community health worker, that's even, they save more money by doing that, I would think, as part of that value. But promoting that the social determinants of health are assessed, and a process for them to really have that connectivity to those resources that are really out there. And sometimes our patients do need the extra help. I mean, I was thinking about during COVID, we established a remote patient monitoring process that we actually, a lot of our uninsured patients, believe it or not, they did have phones. So we partnered with United Healthcare, and they gave us some pulse ox and thermometers, and our community health workers will put in the data in their phones and help them with the app. And then twice a day, they will send the temperatures, the pulse ox reading, and they would talk to the community health worker once a day to hear their voices and see how they were doing. And boy, they could send it up to a nurse if there was some values that were not good. But the feedback of the patients, I said, listen, I was able to quarantine at my house at peace for 2 weeks, because, you know, our hospitals were overwhelmed. So we were kind of triaging, depending on if you can send you home, even though you should be in the hospital, we can send you home. We're going to send you home so we can free that bed for someone else. But having the community health workers actually were integral to that process. And the feedback of the patients was really heartwarming, of how they were not being able, they were telling these ladies, because they're women, the ones that I remember from San Antonio, that said, listen, we would have not been able to quarantine at peace without knowing that we have you. If we need something quickly, we're going to get you, and you will get us to where we need to go.
Yeah, I hear that. And community health workers, promotoras, peers, they, whatever term you want to use, to fall under CHWs, they truly need to be part of the model going forward. But we need to find ways, as you're pointing out, to reimburse properly and incentivize that. Let me check.
One quick thing, Dr. Martinez, just make sure they're not grants, because that's what's very frustrating too, because it doesn't show permanency.
No. We have to have real change and transformation. Grants is a gap stop measure that we all know. You know, it's we're using it, but it's not filling the bill. Let me go to another thing that you brought up, getting to the workforce. And I love that you really went really upstream with thinking about high school seniors. So how would you incentivize them?
You know, I know that we have, how would I incentivize them? Obviously, we have to help them with paying for school, because that I think is one of the main things that is an issue. I think as a hospital system, I know we have some of our ministries or regions where they go into this low-income zip codes, and they partner with their high schools and have some education, where they have them talk to nurses or LPNs or physicians and other folks that go in there and talk to them, to kind of get them inspired and thinking about going into a healthcare career. But I think in addition to that, we have to do something about not loans, but some kind of a way to help them with defray the cost of college. That's.
Oh, indeed. I know the cost of education has gone out the roof, and that's a huge issue, and that's why the Department of Education is part of this health task force, because we have to be able to take a look at how education is, or the cost of education is impacting the pipeline. The other thought sorry, are we at time, Stephen?
We're at 15 minutes, but I did just finish your question, please.
I just wanted to say that one thought I had, as Marcos, as you were talking about that, is maybe standing up programs the federal government could finance across the U.S., and maybe partnering with our Hispanic and Latino universities like HACU and others, to create maybe high school programs where they are formalized, that we bring in our students, for example, to sort of shadow all of you as an example. Can you imagine that? Create the leaders of tomorrow, but also hopefully really implant that thought and passion of going into the medical field and the other professions, not just medical, because we need folks in public health, in nursing, social work, psychology, you name it. But that would be fabulous. Let me turn it back over to you, Stephen. I'll just say this, Stephen. Thank you for keeping us on task. But two, this is the same model actually that we use at the task force with subject matter experts across the countries. So you guys are getting a flavor of what we do practically every day.
Stephen, if I may, I just want to spotlight, I'm sorry to do this, Dr. Esparza, in terms of the conversations around the student and the pipeline. We have here with us an expert. I consider you an expert in that field, and a lot of the work that's being done here locally at the California State University of Northridge as a Hispanic Serving Institute as well. So if you'd like to add a comment to that, I think it's just great how diverse of a group that we have here in NALHE.
The pipeline is the issue, and I think Marcos really hit it on the head. Is upstreaming. How do we even get high school students to even know what a doctor and a nurse does or a social worker does? And I've had the privilege of participating with a local high school who has what's called a health. They have a health task force committee. A faculty member, a teacher there, has taken on the responsibility to put together health-related professions, kind of affinity group for students that want to know about what's going on in the field of healthcare, because that's so broad. I mean, you can go from being a nurse's aide to a physician. So what they do is they invite people to speak, not a big commitment, but come in and speak a little bit about their profession, what it takes to be prepared to do it, the kinds of knowledge and skill sets you need to enter into some of these professions. And I'm just amazed at how many of these students just do not know any of this. And so upstreaming, Marcos, is just a fantastic process that you're doing. I'm really, really pleased to hear that. And then, of course, I'm saving my comments a little bit for later when the panel opens up, but preparing professionals. I mean, I'm the chair of the Department of Health Sciences, and we run a public health program, a health administration program to prepare healthcare leaders. And we also we have a nursing program in our college as well too. So this is very timely for me because they are starting for information about where do we need to go and where do we need to take our programs so that we can better prepare them for cultural competence and outreach to vulnerable communities. So thank you, Ro, for inviting me to this. I really appreciate that.
All right, and before we move on to Laura, I do want to call out the chat conversations. You asked about financing, and Deanna Rumsey, you'll hear later from her. She proposed a capitated financing mechanism. Dr. Martinez, we could spend a whole nother hour talking about that. It is an innovative discussion. I've seen it work, and there are models out there that are showing this and showing savings to do it that way. And then Ellen Nasberg, I'm going to call your comment out. She said, ROTC model, hospitals pay for education and the student gives back a certain number of years based on the financial help. That's a great idea. So just wanted to call out those innovative thoughts. And with that, we're going to turn it over to Laura. Laura, are you ready? And do you need me to present anything?
No, I'm good. I'm ready. I just have to start off by saying hook 'em horns. And I miss my good old home state of Texas. I did want to just chime in on the pipeline of high school students having been a first-generation immigrants and college graduate. Don't forget to educate the parents. It was actually through a fair that my parents learned more about the health educational routes, and administration came up. So I think for especially for immigrants, even undocumented, the parents understanding those opportunities can decrease the fear from the family and then encourage and empower the students to reach out to other opportunities. That just comes from my own personal experience, but I'm here to talk about data and analytics. I'm going to keep tabs on time, Stephen, but I am counting on you. I was thinking it was 15 minutes and now we're going to shorten it to 10. So allow me to share my screen here. I think the host needs to give me that permission before I do that. This is data and analytics is a passion work for me. My day job at the American Hospital Association is leading workplace violence and community violence prevention programs. We can spend all day as to, the role of hospitals in that, but I think one of the areas that, I can correlate my work to data analytics is, the answer is in the data, especially upstream, as everybody has mentioned, especially as you're working to solve some of the downstream issues as, violence continues to perpetuate our communities. So let me try again in sharing my screen. I think we got it now. Let me share and put it on presentation mode. And I think here we go. So why now in regards to looking at data and analyzing the data to truly tell a story is we know Latinos are a principal demographic of the growth here in the US. I think we need to hone in on that message, perhaps give some talking points of the significance of this demographic. And I say that on, from the perspective of continuing to build the case within the health systems to improve investments, transform care, and other ways. I think why it also is important now more than ever, and I think several folks have mentioned it, we do have the largest uninsured population. And this, I can't necessarily tell you too much about the data, but I don't know how it accounts for the undocumented population. And I think those conversations need to be had around data collection. Here are just some of the facts that I threw out here for you. I think there's a lot of different ways that we can look at data, but what is significant for me here are just the impacts on chronic disease, health literacy, access to care. I'll call out the nuances to mental health, not only the services delivered, but accessing that from our community. And then just some of the cultural nuances that, we know is part of the solution in educating the health system to better deliver care. But with that background, I think, again, data and data analytics are very important. So what data should we be collecting? The only thing that I would add, just from learning from my colleagues here, and Marcos, you said it, payer mix. I think that's a wonderful data point that we should be considering as well. But what I would like to point out here is, we have community level data and patient level data, and I'll just make some notes as we go through the presentation here as to where are the access points to the collection of this data, and where does it impact care delivery, because I think that's what we're all trying to improve here. So I think what's important to note in this slide, and I'm going to be focusing on what the ask is in regards to support from federal and state and local agencies, is to really take into account the dramatic growth in data, not only data collection, storage, the data infrastructure, where all this data is actually coming from and what governs that. We do have to note that the healthcare industry is at higher risk for cybersecurity threats. So as we have data collection conversations, understanding the sources, the growth, the infrastructure needs, and perhaps some of the risks associated from that. And again, patient-generated data, protected by HIPAA. However, there's some new things coming into play here, like wearables, and where all that does that fit. So that's patient level data. Let me just focus on community health needs assessments and try to make it really easy from learning from others. So, as you can see here, CHNAs could be a very meaningful approach to addressing health disparities and looking at those long-standing inequities of our system. And I think, this is a fairly new model in regards to data collection, understanding community health needs, part of the ACA. And we still need a lot of work to better understand how to improve not only the design, the data collection aspects of CHNAs, as our nonprofit hospitals are doing quite a bit of investment to do this right, and to get community input and so on. But here's the reality. There's really no studies determining the utility of this data, how useful it is. So yes, you can access publicly accessible community health needs assessment reports and what certain systems have prioritized. but it's really focusing on those outcome metrics, right? And how can we at the same time ensure that we're validating these methods? So that is at the community level. Again, why does it matter? And this is just an example. Eddie, I forgot that you were in Chicago, but just so you know, this is a Chicago and Cook County Health Alliance for Health Equity community health needs assessment. And I think what I just want to note here, and what's important to note, is how much of an impact and an effect it has on the overall care delivery for our patients, to better understand what are some of those factors influencing health. How are we collecting this data? How do we need to educate? And I think we mentioned a lot of, the issues and nuances around comorbidities, mental health and substance abuse. So, this is what, the intention is to build a roadmap. But I think that there's still quite a bit of need to build that data infrastructure. So part of the questions to me were around metrics. And I think some of you, maybe Marcos, you talked about, how do we start incentivizing around some of these metrics? And there's currently none that I'm aware of, and maybe some of you can correct me if I'm wrong, but there's no metrics that are associated to incentivizing the health system's commitment to community health and eliminating health disparities. So, I think I'm going to say it very, very clear. I think the system will transform where they find reimbursement models that are dependable and sustainable. And I think that the metrics are a way to create those accountability measures and those payment delivery models. So what do we need from the government right now in regards to metrics? Well, we need to benchmark. We need to improve not only the data collection, but really start to standardize some of this data. You'll realize that, for example, community health needs assessments, that the disparity of and how they're executed and modeled vary very greatly. So if we're going to start benchmarking at a national level, we do need some best practices there. And I think that that's where some support at the federal level would be helpful. So I put this slide here because I like how, and I've always been an advocate in making sure that the health system embraces public health strategies. And I think we've come to learn that through the pandemic. And you can see here through this public health framework to reduce health equity, not only the importance of data collection, every aspect of the continuum of care, not only upstream and downstream, and where we have this access points to patients. So I think kind of overlaying different models and frameworks to see where we're accessing the data, where can we improve not only in the delivery of it, but perhaps within the data infrastructure. And I in my opinion, it continues to be very poor. I know our hospitals struggle with implementing EMRs, interoperability, as you mentioned, Marcos, continues to be a challenge for our hospitals. But continuing on, I want to just focus on one of our great colleagues, Andres Gonzalez, over in Forward Health. I think he's in Wisconsin. But what I appreciate from this quote here is not only his focus on the upstream, but his ability to focus on creating patient awareness, again, bringing them to the table, educating them. As you can see here, as a leader, he's also finding ways to work with providers, allowing them to see the value at looking at this data. And I think he ends this quote very well by saying, how do we close the gap? I think we can call it eliminating disparities, health equity. At the end of the day, when we look down to the data and the numbers, we're closing gaps. And I know part of the questions, we're looking at different examples of either quality of care initiatives within health systems, or just looking at health disparity initiatives. And I think what's good to note, and some of the examples I provided here, and I think folks will have access to these presentation decks, the solutions are local, the problems are local. So yes, we can look at what data to collect, but it's more about building a better infrastructure for data collection and empowering for local leaders to better understand their communities, because we know that the interventions are going to be local. And I think that Eddie did a phenomenal job at kind of, him boots on the ground kind of shows that it's an evolutionary process. It's about continuously looking at data and continuously finding ways to improve to meet the needs of the patient. So I'm not, I don't have the good fortune like Marcos and Eddie to be that close to the patient encounter. I'm looking here from a 30,000-foot view. But what I can tell you is that organizations across the country are doing great work around looking at data to eliminate health disparities. I think what these organizations need is a lighthouse. We need to understand what our point B and what are we doing to actually build a stronger infrastructure as our data continues to grow and our data needs. So I will stop there. Some more examples here that I'll leave for the group to review. And Stephen, I didn't hear you call out my 10 minutes, so I'm kind of proud of myself, but I'll definitely take questions from the group.
Very good.
Well, Laura, let me start with this question. Definitely love the overview you just gave. In reference to the data and metric infrastructure you're referring to, as you think about the federal government, which unit of the federal government should this responsibility belong to? Because as you're pointing, we need a point of light, but we don't want it to be so diffuse. We don't know where it's coming from. So from your opinion, where would you put that?
Well, I don't want to get too political because I don't know if I know the entire background, but I know that ARC was the Agency for Healthcare Research and Quality, was fairly well funded and doing a lot of great initiatives, but their presence has been lacking as of recent years. Again, I don't know the politics, but I really do think ARC is well set to support the health system in looking at improving data collection and analysis. I think other offices could offer support, like Office for Minority Health, to create some of the, make sure that they're aware of any cultural nuances and make sure that that data is well stratified to show some of the minority communities and their concerns. But I don't know if that's the best answer, and I would definitely ask my colleagues to chime in, but I would put it under ARC.
No, I appreciate that. Thank you so much. Going from a different perspective, the CDC is one that's supposed to be collecting a lot of this data. One of the things that we found out during COVID-19, and this was unfortunately happening across the country, so I'm not pointing my fingers at any one of you or an institution. Just in general, what we've heard, even the basic data like race and ethnicity wasn't being collected with the COVID-19 data that was being sent. And of course, they did that whole switch on us from CDC to HHS, which was, I'm sure, just really a boondoggle for you guys as you're trying to pivot to that. But any thoughts there, Laura, on, I'd love to see, as you pointed out, the vision where the social determinants of health, we have data and metrics, but we're struggling with even just the basic real data, race, ethnicity, and language. So how do we ensure we get first that core data to be part of the DNA of this healthcare system?
Yeah, and I'm going to try not to step into any thick political waters here because, again, I work for the American Hospital Association, and when CDC was asking the HHS to look at that data, we were being bombarded with requests. We do a very large annual hospital survey and are able to do quite a bit, and obviously have worked with the other organizations that do similar work. To very frankly answer your question, it is a hot potato because the data infrastructure is so poor. If we talk about perhaps, I'm just going to throw an idea, mandating certain reporting on, not only real data, but social determinants of health, Z codes, et cetera. I don't know if we have a reporting system that could manage what is being asked of the health system. So I think that we need to bring certain folks to the table from the IT and big data, to having some of the administrators to really see that what we're asking is feasible within the health system. And then just another point in regards to requesting some of this data from federal agencies. That is under the assumption that federal agencies are a collaborative partner to the health system, right? It is, oh man, a lot of the time is not as collaborative as we wish it is. It is more authoritative, if I may. Regulatory is probably the best word. So I think if we know we haven't created the right system, even close to an ideal state, then we need to go back to the drawing table and start working more collaboratively to ensure that, from definitions to categorizations to the very basics of data are being considered, and then from there continue to build. Because at this point, we're just asking hospitals to churn information that, yes, they adapt and they collect, but they really are left to their own devices. And they do great work across the country, don't get me wrong.
No, I greatly appreciate that, your comments. It does make me think of the fact that here in the United States, we have amazing technology that's being developed. However, it is not equitably being implemented across the United States. And that includes not just individuals, but even our organizations. To your point, federal government obviously has a power to convene. Who should be at that convening? You mentioned a really key word to me, which is IT. As soon as I think that, I'm thinking really more the private sector. If you were to bring together who needs to be at this table to develop what you just laid out for us, what would be the big components or the big, sort of sectors? I don't want your name organization specifically,
Okay.
but, who should really be at the table to be able to develop this?
Well, I'm going to highlight
15
two.
minutes.
All right, I want to have two specific roles. I think payers, commercial payers are important. I think in the way they invest, in the way they collect and incentivize. They're huge influencers to the health leadership and delivery. But secondly, are really looking at technology and software vendors. They are truly steering the system to go based on products and services being offered, right? Because we don't have the time and the resources to build our solutions. So we're counting on these really external vendors to answer some of these questions. They're often not regulated. So I really think, for example, Allscripts, looking at, I'm blanking on the other one. It's the biggest one, but really bringing some of these for-profit commercial, looking at health system or healthcare as a consumer-based industry rather than just care delivery. I think will help in the way we start transforming the way we partner.
Thank you.
Awesome. It's another big one. Yeah. Okay, wanted to open it up. Any additional comments from our audience before we move on to Deanna? Okay.
Thank you guys. Appreciate it.
Thank you, Laura. Did want to call out some chat conversations. The Community Health Needs Assessment, better if I say it than say the acronym, are a good way, a good opportunity. So I want to underline that. And then Deanna just put the DOJ needs to be on board. Otherwise, there won't be any teeth to the mandate of the reporting. So there you go. All right, with that, we've got our last panelist, and then we open it up again for everyone to comment. Diana Octavio is going to talk to us about communication and community engagement.
All right, well, thank you so much. I appreciate everybody's time, and I am incredibly honored to be speaking on this panel. I've enjoyed everybody's topics and conversations, and I feel like we're all kind of speaking and beating the same drum. So first of all, I like to start with definitions so that it's very clear what we're talking about. So when I talk about community engagement, I'm simply talking about bringing people together around a shared idea. So this is really at the heart of representative democracy, right? Kind of bringing people to the table and really honoring their voice. So I'm a community organizer. That's what I currently do. I'm also a candidate in the Masters in Public Health program. So when we're talking about social determinants of health and all of these pieces, I'm thinking, we've been talking about this for a long time. We've got a lot of data. Why haven't we moved forward? And that's a topic for another time altogether. So there are some historical giants in the field of community organizing. I'm not one of those people yet. But I am committed to social change and social justice, because that's really what community organizing and community engagement is about, right? It's about disrupting these disparities that we see, that we've been seeing for generations, that we've been talking about, that we've been collecting data. It's we're all done talking about it. We need to start having action items behind it. So one of the key points I'm going to talk about is disrupting those disparities in our communities. And one of the most powerful tools is engaging citizens as citizen experts, really, because people don't want to be a service. They want to be a valued central part of their community. We talk a lot about community-based participatory research, academics kind of swooping into communities with their interventions and their money, and they're like, you need this and you need that, and then they swoop back out, and there's no follow through, and there's no skin in the game because there's no relationship. So when we talk about this, we need to have a really candid conversation about relationship and what relationship truly means. It means a give and take. It means reciprocity. Because if you're asking community members to be engaged, you're asking them to give something up. You're saying you're going to have to give up your time with your family to come to this community engagement meeting. You're saying to pastors at churches, you're going to have to give up some space so that we can have this community event here instead of having a church event. And just being honest about that and really honoring that. And then letting them make that decision. Is this something I feel comfortable in giving? What are you going to give in return? Are you truly invested in making my community better? Or are you just here to data, get your money, get your grants done, get your little name on a paper, and then swoop out again? People don't need that. They've been there, done that, and bought the t-shirt. There's a lot of historical trauma around these kinds of things happening. And that's not the kind of community engagement I'm talking about. So Rosa Beth Moss Cantor, who is a wonderful professor at Harvard University, she teaches leadership skills. She talks about not giving up because anything can look like a failure when you're in the middle of it. And if you quit right then and there, then it's absolutely a failure. You got to keep going. You got to be invested. So one of the things we've been talking about, people have been talking about community health workers. They're a vital part of this conversation. People have already mentioned the funding stream. So when we look at the data, that is the #1 reason that community health workers say that they have a barrier in their work is that funding stream, because it's so tied to grants, which are time-bound and task-specific. And so we need to change that. We also need to reimburse them appropriately. We need to show them that we value them, right? They've got bills to pay. They're out there doing amazing work. And what we've seen is that their value is 4 to 1 when we're looking at those dollars, because they're able to get into spaces and places and do work that other people can't do because they're embedded in the community. They speak to the community, they're a part of the community. So they can talk about mental health, which is a subject that is highly stigmatizing, especially in the Latino community. When we look at the disproportionality of mental health issues in the Latino community, especially suicidality and suicide ideation with our young Latinas, right? We see them internalizing a lot of stress, and we're seeing these horrifying numbers, but they can impact mental health pieces. They can talk about substance use disorders, interpersonal violence, sexual and reproductive health, right? Tons of research on HPV vaccinations and safe sex practices, and community health workers being able to do that work because they're able to have those intimate conversations in ways that are vastly different. Certainly, we've seen a lot of them being used in chronic disease management, again, because they're there. When we talk about diabetes prevention, right, there's all of these menus and, eat kale and do this. And it's like, what? Like, first of all, I may live in a food desert. That's not food that I'm comfortable with. That's not what I do. That's not how I cook. Help me personalize these intervention strategies so that they speak to me, because oftentimes what we see is we create these intervention strategies and then then they fall off the rails. And what's the first thing that people say? Oh, they're just non-compliant, right? They're just non-compliant, they're disengaged, they didn't show up to their appointments, blah, blah, blah. Not looking at all of those social determinant factors, right? So community health workers are critical, and we need to their definitions, right? Because then this goes back to the reimbursement model. Right now, there's 100 different titles that fit under that umbrella of community health workers. That makes it really hard to collect data. Laura was talking about data collection. It's really hard to collect data on interventions and outcomes when you're dealing with all of these different definitions of what is a community health worker? I don't know. What exactly are they doing? So we need to get clear on the definitions. We need to get clear on reimbursement. We need to find strategies. So that's one big part of the conversation. Also changing the narrative and changing the language. there's something really frustrating to me when we talk to communities and we point out all the things that they don't have. We say, oh, you're marginalized. Oh, you're disproportionately affected. Oh, talk to them from a space of strength. Because what we've learned, I come from a strong mental health background, is the narrative you tell people, they start to tell themselves. And so they don't start seeing all of the things that they do have. And we need to work from a strength perspective in communities. That's the way we're going to harness the skills and the assets and the resources that they do have. One of the things that shocked me was that I was taking an epidemiology course when COVID hit, and they were like, "Oh, we need contact tracers," and I thought, well, has anybody asked the abuelitas and the tias and the comadres, because they know everybody's business. They know who's hanging out with who and who's doing what. And why can't we? Why can't we mobilize as public health practitioners? If we can train college students, we can train community members, right? Because they bring so much richness to the table because they're already embedded. They already know, they can get into those spaces. So it's a really beautiful way for us to utilize the talent that is already embedded, and to treat them like content experts, because they are. They're experts on their lives and their communities. They know what they need, and they need to have a little bit of power. And that's the other thing I want to talk about. I want to talk about power sharing, and that's a little uncomfortable sometimes for people, and I get that. But one of the things we have to shift is that power dynamic, because when we're talking about community engagement, we're talking about power sharing. And one of the things that is concerning to me is when we have people who have a lot of power and they say, well, I'm not going to give that person power because what would they do with it? You know what? First of all, that person already has power that you don't know about. So I'm inviting people to have conversations with community members and say, what power and influence do you have, and what additional power or resources do you need? Because that's the conversation. If it was just about throwing a bunch of money and interventions, poof, everything would be better. Obviously, that's not what we're talking about. So we need to have a conversation about power sharing, and about tapping into those community members. So let's see, I'm just kind of going through my notes really quickly. I tend to get very excited and passionate about all of these things. Talking about the system. So we've been talking a lot about systems. Laura talked about some of the data pieces. I don't know if the system's broken. I suspect that it's working exactly the way it was intended to work, which is to disproportionately affect a large population within this country. And that's very disconcerting. And so I think we need to start looking at those pieces. I had mentioned the Department of Justice. I just sat on a phone call today talking about implementation of health equity and accessibility for individuals with mobility issues in doctors' offices. Now, ADA has been around for over 30 years, and doctors' offices still aren't accessible. Riddle me that, because there's no teeth behind the regulation. So doctors' offices and community health clinics and on can say, well, so what if I don't do this? They can file a lawsuit at the federal level. Okay. That's ridiculous, and it shouldn't happen that way. And so too, when we're talking about health inequities and disparities, we need to have a conversation about putting some teeth to the regulation, because what history has taught us is if there's no consequence, then people will kind of skirt around the perimeters of those pieces. And we don't want that to happen anymore. I think this pandemic has shined a light on the fact that when that happens, a lot of people get hurt. So promotoras, we've talked about community health workers. Somebody talked about grants. Let's talk about some equity in grants, because when we talk about who gets those federal grants, oftentimes it goes to people who can hire the best federal grant writers. And that's not always people who need the money the most. So potentially looking at building in a health equity lens when we're talking about distributing those health equity those grants and those dollars. Somebody else mentioned the National Institute of Minority Health and Health Disparities. If we could make that branch a little bigger, that would be nice. Right now, it's incredibly small. And if we're talking about health equity disparities, I think, allowing that to have a little bit more expansion so that we could get really good data on the federal level would be wonderful. And then, partnering with faith-based leaders. People have shown that they are more willing to show up at a at a faith-based location than they are to a community health clinic. You can get people in for those diabetes and those, and their blood pressure screenings if you have them at places where they feel comfortable, where they have feelings of trust and safety, right? And so I think partnering with community faith-based leaders is really, really important. And then, we were talking about the federal component. We need to have a conversation about the American Indians and Alaska Natives. The federal government is tasked with providing healthcare. What we've seen is that has not necessarily come to fruition. So I would encourage a conversation about spending dollars and resources, because everybody is. And so when you go to other minority groups and you say, we've got this solution, it'll be okay. They're like, I see how that worked out for so-and-so and such and such. It didn't work out too well for them. So again, we need to have conversations about relationship, building them, sustaining them, and maintaining them. So
Tiana, we're at 10 minutes.
We're good. I'm done. Thank you so much for listening. I really appreciate this time. This has been such an honor, and I'm happy to answer any questions that you may have.
Deanna, you like the other presenters have covered a tremendous amount of ground. I commend you on the amount of critical thinking that went into this, your presentations and the documents that I have. One thing I want to follow up on before we open it up, Stephen, to others, the conversation on power sharing. I think that's such a critical one. In your mind, how would you envision from the federal level that we would actually stand that program up, so to speak?
Yeah. Somebody talked about everything being local and all politics is local. And I think when we talk about power sharing, we need to have a conversation about helping those researchers be that bridge with other community members and introducing people to other individuals in the policy and lawmaking spheres. Because what ends up happening is they say, yeah, I know that I have this representative or this senator or what have you, but they've never had a conversation with them. They feel incredibly intimidated to be in that space. And so if we can support an atmosphere where that is kind of bridged, where potentially a hospital CEO is taking somebody and saying, hey, I want you to meet Representative so-and-so or such and such, and just have that conversation and prime that pump and say, this is how you talk to a senator, this is how you talk to a representative, because there's language and there's etiquette and all this schmoozing that goes on. But if people don't know how to do those things, real challenge and struggle. And so what they do is they just kind of pull back and they say, well, I guess I just can't do it. And it is what it is. And I don't have power. And if our legislators don't hear from constituents, they will lean into those people that they do hear, which are the special interest groups and people who can pay lobbyists. So, I think that would be a really wonderful experience for community leaders to have.
Thank you so much. Back to you, Stephen.
All right, opening up to the audience to see if they can contribute any other thoughts to this. It is a broad topic, so I do know I'm reading some things. My comment that I just sent on the chat is it goes back to teaching employers and politicians and everyone else about unconscious bias, right? So if we start there, then we're going to start a narrative of power struggles, because that's part of it. Unconsciously, a title gives a power, and also a color of the skin can also inadvertently give a power distinction. So those are things we need to start talking about. Ellen Nasberg says, can the various state hospital associations help with the political introductions and potential policies, or political? Did we say that correctly, Ellen? That may be misspelling.
I feel like I want to chime in on that one, just from the AHA perspective, having worked with state hospital associations. I think it's always a matter of finding ways to collaborate, right? It's a give and take when forming these types of relationships. But a model that has worked well, Ro and I have had conversations about kind of the two arms of NALHE's mission, which is promote and educate on policies that empower our communities, but also focusing on the health equity. So, advocacy days where messages are crafted, where folks can actually take them through and talk to their representatives it needs to be a guided and engaging process. It's not a one and done. It's not just a comment model letter. So I think, could NALHE, could other perhaps health professional associations, state level associations, local, as Deanna mentioned. So I think there's maybe more around sharing models to engage, the constituents and other leaders in the practice of advocating for communities.
Let me add something to that. Deanna started this, and Laura, I love those comments you made. I'll share with everyone. I'm also on the board of the National Hispanic Council on Aging, NACOA, and they're up in the Beltway. I used to be former also chair of the board, just full disclosure. However, one of the things that we've developed over the years is called the Líderes program, which is the leaders. But the leaders here are our elders, our abuelitas and abuelitos. And NACOA has developed a leadership program at the community level, working with the elders for them to become policy savvy and get the skill sets they need to do exactly what you were describing, Deanna, about talking with your elected officials. Because as you pointed out, and it was Tip O'Neill, all politics are local. It is so true. You got to start local and you can work your way up. There's 4 programs that currently exist, and you can go to the website to learn more about the Líderes program. Miami, we have one in Dallas, Los Angeles, and our new one is down in the Rio Grande Valley.
Good.
So imagine if the rest of our organizations, to your point, Laura, were to do something similar. So these are elders, but by golly, we can use folks across the entire age spectrum, including youth, to be at the table and really, engaging with our policy makers to be not only hearing, but being accountable to the community. So I love that. Thank you.
That concept extends to other minority groups as well, prevalent in Asian and Native Americans. So, I mean, it just lends well to different minority groups. So. Others.
I like Laura's idea of sharing models, because I think that's key. For a lot of us, we keep it to ourselves, and we don't spread the wealth. And I know here at CSUN, we have an annual rotation that is made available to all public health students, where they spend a couple of days up in Sacramento, meet with representatives, and learn how their role as a public health professional can affect policy, and vice versa, how policy can affect public health. And we purposely, intentionally do that so that our students get that comfort level of having that conversation with politicians, and we prep them as well as we can. But at the end of the day, we want them to be themselves and express what they're feeling and seeing in the communities. So that's a model that we use. I'm sure other universities are doing something similar. But
yeah, and just to follow up on that, Dr. Esparza, Congressional Hispanic Caucus Institute works with their fellows to put on Hill briefings. And it's based on, their fellow projects. And, I can speak to a few that I have been a part of, but, one of them was talking about housing and health. And it really showed not only in building that pipeline, but it was also engaging congressional leaders to how it is to work with minority leaders. I always tell Ro that I'm kind of like the poster child for internships and fellowships. And I think that providing those great opportunities for minority, leaders and emerging leaders are great, but we also need to focus on breaking through. And what I like calling that is, going from kind of an apprentice mode to really becoming a champion. And I think that that's what, NALHE is so well positioned to do. In addition to sharing models, is really looking and how in partnership with others, we can start building this coalition and unifying this voice. Because as much as I love mi gente, one of the criticisms that I may have to some of the work that we do is we really need to unify our voice. I think this is very motivating for me, because it really seems that all the speakers today shared notes and we didn't. but that lets, that is a great example of, we're all doing some great work, but building that platform for knowledge sharing across the country, across industries would help us really advance, not only through innovation, but, through meaningful engagement. So I probably it's kind of went on a rant there, bro, but
No, I'm with you.
thank you for letting us share.
I'll share with you. I think one of the conversations we initially had is wouldn't it be ideal if we had some sort of central repository? I'm not sure if it would be overseen by the federal government or not, where it would host all of our community health needs assessment. I also oversee the community health needs assessment process for Children's Hospital in Los Angeles. And Marcos, I know to take a look at some of our other hospital systems needs assessments, interventions, the data, it is a tough thing to navigate. You have to go in through some of the websites. Well, wouldn't it be phenomenal if all of these needs assessment, the data, the interventions, the outcomes, the learnings, were all in one centralized repository we can access?
And I know that some of us are in a better place than other hospitals, but as a baseline, expecting for all this information and data for the CHNA to be looked through an equity lens, it's critical, because that's not even there. It's like, diabetes, and then it's report globally. Like, okay, drill it down, please. What are the populations that really need help? And it's just mind-boggling. We're doing it now. I'm requiring it for our CHNA cycle this time, but that's not a requirement. That's because I'm asking our system to do it.
Steven, let me make one comment. I love what you guys are talking about, and Ro, your idea, what it makes me think about is that, we've had these centers of excellence that the federal programs have come out. Why not create a centers of excellence exactly to what you just sort of described and designed, where to each state, one maybe academic center is awarded that center of excellence grant to be able to stand up a data repository center where the community health assessments can come to and do the kind of work you're talking about. With the charge, they must then disseminate and obviously, coordinate with all the other centers in the hospitals within your region. I mean, we could do it by state, or we could even do it by the regions, that HRSA already has. I mean, HHS already has. It could be done different ways, but I love that concept and idea of yours, because there's a lot of data out there that we're not mining and utilizing and turning into evidence-based approaches.
Right, and to something Laura said, I think that could be a great opportunity for NALHE as well within our own members or hospitals. Maybe we can start creating some sort of repository of our own member needs assessments, if that's an opportunity, right? So yeah, that's a great idea. That's a great idea of documenting.
If I could make a comment on CHNAs, and this is might be one or two dimensional from my perspective, but yes, it matters for tax exempt hospitals, right? That is the incentive for them to do it and report it out, make it publicly available over 3 years. I think that, we obviously are telling you that there's good data, that it's a process that can be improved, but perhaps can start going beyond tax exemption. So, that is perhaps a longer term conversation, but I do want you to know of the impact that I have witnessed within the health system since CHNAs were implemented. They have been delegated oftentimes to, for example, the community benefit department, diversity and equity. So it doesn't have the direct line of sight that I believe it can and should have to the C-suite. Perhaps some are doing it well, but it is every 3 years. We assume the process itself is extensive. The report is going to create a strategy for execution for 3 years, but there's not strong accountability measures, as Diana mentions, the teeth that we need behind it, but also really asking ourselves, are we getting the buy-in from the very top? Because I think the outcome of doing community health needs assessment is to transform, to improve the care we deliver. So, if it stays at that level below, that's probably where it will stay. So just all great comments. It's just making sure that this continues to get elevated to the C-suite.
So Ro, you and I have talked about this ad nauseum about getting public health and the medical models back together, right? Because historically they were, you know, side by side at one point. And putting on my public health hat, you know, the conversation needs to be had again about getting people around the same table, because public health is really good about understanding health behaviors and why people are apt to change and why they're not, and what are some barriers, whether those are social determinants of health or, you know, behavioral modeling or whatever that looks like. And so I think what this pandemic has shown us is that we can give people information, but if we're not supporting them and making those health behavior changes, nothing is going to change. And we're just going to be back to the place where we were. I also wanted to talk to one of the points that Eddie had brought up about the public health, different entities, and having a conversation about having some consistency, even within the same state, would be wonderful, because I'm here in Colorado and I can tell you Tri-County Health put out one mandate. Douglas County said, we're going to be the Wild West and we're going to do what we want and nobody has to wear a mask and we're not going to follow, you know, and it's, the problem is that it becomes mixed messaging to the community, and people travel from one community to another. And so it's not like people are going to stop on those community borders and be like, oh, I'm entering Douglas County, no mask. Oh, I'm now in Denver now. And it's just incredibly confusing, which leads to people not believing the messaging at all. And they say, well, it's a bunch of hooey anyway. I'm not going to listen to any of it. You know, the CDC says this once. You know, I was on a conversation with health, with educators, and they were saying that, you know, one day it's like, yep, kids don't have to wear masks, and now it's kids do have to wear masks, and the transmission is this versus that. And it's like, we need to have consistent messaging, otherwise people don't trust us if we're kind of all over the map. So
I'd like to ask the group a little more information about your experience with literacy, because, you know, in my experience, we always talk about, well, I hear providers talk about, well, they're not literate, they don't understand what we're telling them. And what they're speaking to is English literacy. Doesn't mean they're illiterate. They know how to read and write Spanish, perhaps. So do we put our information in a way that is understandable in the language that they know and can read? So it really bugs me when I hear people say, well, they're not literate, and they're really talking about English literacy. But that kind of leads then to the issue of the amount of misinformation that's out there for the Latino community about stuff like COVID and the reaction to the vaccines. And it's mind-boggling what we're discovering here in LA about the amount of misinformation. And one thing we discovered in a study that we did about teaching Latino community about hospice services, because hospice is not really well regarded, or kind of, it has this veil of secrecy, is we discovered that the Latino community likes to see this on TV, on video, and that's where they get a lot of their learning from. At least that's what we learned from our study, is that video presentations with people that are them, look like them, speak like them, does so much more to help them learn about their condition, about COVID, about vaccines, about hospice, whatever it might be. So I'd love to hear what some of you think about the whole issue of literacy and how we're communicating to our communities.
I would love to jump in from two perspectives. One, as a patient, while undocumented and young, and then two, as you know, more health literacy than perhaps my parents had, and responsible for helping them navigate. So let me just tell you, my father is a dentist and was an anatomy professor back where I come from, Honduras. So he understands health, obviously through his lens, right? But when he came to the US, it appears that it didn't matter the amount of knowledge he had regarding health or healthy eating or healthy best practices. If he didn't understand the health system, then he didn't trust it, right? So it was not about talking about his symptoms or accessing, for example, a primary care doctor it was not understanding what a deductible meant, not understanding what's the Medicare Advantage. And so, really understanding health literacy, not only through the lens of, health and mental health, but through the lens of navigating the very challenging systems, and I'll just finish by saying, I've had multiple orthopedic reconstructive surgeries. The first one when I was 24. I was undocumented at the time and advocating for, health insurance companies, et cetera. I also think that, when talking about health literacy, particularly for the Latino community and perhaps other minority groups as well, we need to consider generational gaps. I am very different from my parents, but yet in regards to what data you're collecting, we're going to look the same besides our age brackets. The nuances of, even regions of Latin America, all of this will take into play. And all I can say is it hasn't made it into the conversations. I know we're asking questions around the 30,000 foot view. What can we start doing to improve? But I think, Dr. Sparks, that you're getting down to kind of some of the local solutions, what you're seeing. And I think, data collection is important, but really getting down to, we say this a lot, we're not a monolithic demographic, right? So what are we doing to better understand what makes us, what we can help not only identify ourselves, but help others understand. I don't know how many of you guys have questions about what's the difference between Hispanic and Latino, what does Latinx mean? I mean, there's still some things and, some forming and norming that we need to do as a community. I don't know if that answers your question, but I definitely feel you, Dr. Esparza, that, there's a lot to be explored.
I was going to add just one quick thing. With the whole, I think in the public health world, we all know that at a minimum, 5th grade level, when you have information for patients to take home. However, when it comes to Spanish, we're just like, we're begging. So we're like, you know what? I don't care what level it is. Can you please translate this thing? And nobody talks about 3rd grade, 5th grade level literacy of this document in any of our health systems. And what sometimes I go and see stuff in Spanish and I'm like, you know what? I have no idea. I have to be a JD to be able to understand what you're trying to tell me. So that is another issue. I think we do a good job in English in terms of the 5th grade level piece, but when we translate those things, which we're required to, there's no requirements of any.
If I can add, I'm very fortunate as an FQHC, 51% of our board are consumers. So they keep it real with us. And I appreciate that. It's nothing like going to the board and it's daunting to say, they're consumers. They see when they come into our health centers and we're presenting, yeah, I see this, or no, I don't see it. But really looking at also patient advisory groups to really help us, look at this. What does this say to you? And how do we make sure that people are understanding and comprehending the message that we want to deliver? It's still a challenge for us, and we know that to be true. But that has been hugely impactful, and more of definitely healthcare. Their board needs to really look like the consumers that they're taking care of. We don't see that yet. As an FQHC, we're fortunate, but we still have a lot to go in that area.
I just add that, and I totally agree with the health literacy comments. And so Salvador, thanks for bringing that up. But getting to Deanna's point, we need to put in teeth into what already exists. As an example, I'm sure maybe some of you have seen the studies that have been done on the class standards. And we're lucky if a third of our ERs and hospitals, in fact, are even following these standards. So that means that the majority of, unfortunately, of our institutions in health are not, and let alone some of the other ones. So FQHCs, I think they're fabulous because I've worked with them as well, and they really do walk the walk because of their boards. And so to you, Eddie, hats off. but we need to bring the rest of us up to the plate, so to speak. But Deanna made an excellent point about there are some already good, rules and regs out there and laws, but the accountability is lacking.
Yeah.
So we need to start pressing that issue as well.
Dr. Martinez, I want
Stephen, this has been great. Yeah, I
Yeah.
was just about to say, I've got another call that I'm going to have to go to soon.
Yes, thank you very much. The follow-up to this is we're going to get you all the presentations that we did, and hopefully you'll have more questions for us, and we're happy to reconvene if you need anything additional from us. Thank you again to all the panelists. I know you prepared a lot for this, and I just on behalf of all of us, thank you very much for your time.
And I'll just say thank you, Stephen. Thank you, all the presenters and those that have commented. Your passion and your heart comes across, and I just love that about Hispanic and Latinos. We put it out there, and I think that you guys are fighting the good fight. So thank you so much. This has been just amazingly educated for me. And like I said, I'm going to take this to the task force. Thank you.